Are the meeting platform hosts ready to begin?
Yes.
Madam Chairwoman, are you ready to begin the hearing?
I am.
Madam Chairwoman, please perform your countdown.
The committee will come to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. The committee procedures for remote hearings remain the same. If you are experiencing connectivity issues, please make sure you or your staff contact our designated technical support so those issues can be resolved right away. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteranaffairs.hearing@mail.house.gov. Without objection, members will be recognized in order of seniority for questioning witnesses today. This will make it easier to ensure all members participating have an opportunity to be recognized. I now recognize myself for an opening statement. So good afternoon. Thank you all for joining us today for the Health Subcommittee legislative hearing. Today's agenda includes a total of 8 bills, several of which are focused on addressing the needs of aging and disabled veterans. Importantly, we will discuss the bill General Bergman and I have introduced, H.R. 6823, the Elizabeth Dole Home and Community-Based Services for Veterans and Caregivers Act. This bill would enable aging and disabled veterans to receive the supports they need to live at home. The programs outlined in my bill are evidence-based, cost-effective, and most importantly, wanted by aging veterans. Expanding access to these programs means we can delay, if not outright prevent, a veteran from needing institutional care. This means families can stay together, caregivers are supported, and communities remain intact. Our veterans deserve no less. This bill also serves as a solution to much of the heartache around the changes to the program of comprehensive assistance for family caregivers. We refer to this program as the caregiver program. Those who are discharged or denied from the caregiver program and need assistance at home will likely be eligible for the programs in my bill. There is no service connection requirement, only a medical need. Lastly, I want to extend my sincerest thanks to Senator Elizabeth Dole. Her tireless efforts on behalf of veterans and the family caregivers that love them has inspired us all. This bill has been years in the making. It is the result of unrelenting advocacy by dozens of veteran service organizations, but particularly the 3 before us on the 3rd panel today, the Elizabeth Dole Foundation, Paralyzed Veterans of America, and Disabled American Veterans. Thank you for your efforts, and your efforts are truly changing lives. In closing, I look forward to today's conversation. Your expertise and input are valuable to us all as we craft legislation. With that, I'd like to recognize Ranking Member and General Bergman for 5 minutes for any opening remarks he may wish to make.
Thank you, Chairwoman Brownlee. It truly is a pleasure to be here in person, finally, with you and all our fellow subcommittee colleagues and witnesses, because what we can read in people's faces is always the truth, because your expressions cannot hide it. And I'm glad to see the expressions here of the smiles. And sometimes, as you know, in life we see frustrations, but that's a story for a different time. It's a pleasure, again, this afternoon, as we consider 8 pieces of legislation to improve the care that veterans receive through the Department of Veterans Affairs healthcare system. I am proud to co-sponsor 2 of the bills on our agenda today. One of those bills is H.R. 6647, the Relieve Act, which was led by Congresswoman Kathy McMorris Rogers from Washington. It would provide a 60-day grace period for newly enrolled veterans to ensure that they are eligible for reimbursement from VA in the event of an emergency that requires them to seek care at a non-VA medical facility, even if they have not yet had an appointment in the VA healthcare system. That would give veterans who are new to VA the peace of mind to know that they are covered should disaster strike before they are able to see their VA doctor, which we know can take far too long in some instances due to long wait times and other access issues. The other bill that I am proud to co-sponsor is H.R. 6823, the Elizabeth Dole Home and Community-Based Services for Veterans and Caregivers Act, and I'm grateful and thankful to Chairwoman Brownlee for working on the bill together because this is important and is an example for future. It is named after former Senator Elizabeth Dole, who has dedicated her life out of elected office to championing the causes of caregivers and ensuring that veterans and all Americans can maintain their dignity and independence even through the most difficult disabilities and illnesses. The Elizabeth Dole Act would further the work and make it easier than ever for veterans and their families to choose how and where to live out their twilight years. One of the ways that veterans may choose to do that is by living in a medical foster home. Another bill on our agenda, the Long-Term Care Veterans Choice Act, which is sponsored by Congressman Clay Higgins from Louisiana, would allow VA to pay for veterans to live in a medical foster home if VA would otherwise be responsible for covering the cost of care for the veteran in a nursing home. Those veterans who have service-connected disabilities rated at least 70% should never be forced to choose a costlier nursing home to the more residential, familial atmosphere that medical foster homes provide simply because they can't afford otherwise. The Long-Term Care Veterans Choice Act would ensure they don't have to. I'm in full support of that bill. I'm also in full support of H.R. 5754, the Patient Advocate Tracker Act, which is sponsored by my friend and fellow Michigander, Congresswoman Lisa McClain. Her bill would require VA to ensure that veterans can submit complaints to patient advocates online and track the status of those complaints online as well. This bill was the brainchild of Navy veteran Cameron Zabowski during his time as a Veterans of Foreign Wars, Student Veterans of America, Student Veteran Fellow. Cameron is here with us today. In fact, I had a chance to say hello to him earlier, and I want to just take a moment to thank him publicly for the hard work, the diligence, and the advocacy on behalf of our fellow veterans. Way to go, Cameron. Nice job. Cameron's work also led to another bill, H.R. 5755, the Veterans Patient Advocacy Act, which is sponsored by Congressman John Molnar, who is also another fellow Michigander. We're sensing a theme here, at least in this hearing. I hope that his bill will be considered at our next legislative hearing, since it is another critical piece of that puzzle in ensuring VA's patient advocate program, that it is working as well as our veterans need it to. In the meantime, I look forward to hearing more about each of the proposals on today's hearing agenda from our colleagues on and off the committee and from our expert witnesses from VA and the veteran service organizations. I thank you all for being here or for being with us virtually to share the feedback and your recommendations. And with that, Madam Chairwoman, I yield back.
Thank you, General. And so we will now welcome our first panel, where I will recognize Representative McClain for 3 minutes to discuss her bill, H.R. 5754, the Patient Advocate Tracker Act.
Thank you, Chairman Brownlee, and thank you, Ranking Member Bergman. The Office of Patient Advocate was designed to provide an outlet for veterans to express concerns or provide feedback for the level of care that they receive during their treatment at any VA facility. My legislation, H.R. 5754, the Patient Advocate Tracker Act, would make it easier for veterans to connect with patients' advocates by creating an electronic system for the veteran to submit, track, and appeal their concerns. The VA's current system allows for employees only to track these complaints internally. This often leaves the veteran in the dark on their cases and at times frustrated. The system my legislation proposes would allow a veteran to file a complaint electronically with the patient advocate and view the status of the complaint, including interim and final actions that have been taken. This bill should not require any additional appropriations. Funding for the upgraded interface would come from VA Offices of Information Technology dollars, which is the same pot of money they use to fund the current system. In fiscal year 22, the VA's Office of Information Technology received around $5 billion. This common sense legislation gives veterans more input over their health care and increases government transparencies. I thank this committee for considering my legislation, and I yield back.
Thank you very much, Ms. McLean, and we will now recognize Mr. O'Halloran for 3 minutes to discuss your bill, H.R. 5941, the Fairness for Rural Veterans Act.
Thank you, Madam Chairman, woman, and ranking member. Appreciate the time. I appreciate the committee discussing the Fairness for Rural Veterans Act, legislation that I introduced following extensive conversations with veterans living in the mostly rural communities that comprise much of northern and eastern Arizona, and some veterans throughout the nation. Under the current law, the VA uses a priority list based on demographics and need to determine rankings for projects to receive funding. The list does not consider how far veterans and their families have to travel. This process makes it difficult for projects in rural communities to compete for the funding. This legislation would create a new priority group for rural areas for the VA to consider in its process to rank proposed projects. Importantly, rural Americans and those in rural Arizona simply lack access to the health care system. We lack primary care doctors, including mental health providers, and we lack specialists whom many veterans rely on for the care they need. We lack nurses and other non-physician providers. And making matters worse, access to reliable broadband means that telehealth is not always a viable option for many of our rural veterans. This means that health needs in rural communities can be quite difficult for those residing in urban, suburban, and exurban areas. Simply put, the VA needs to improve its focus on our rural veterans. In particular, the VA must explore novel ways to ensure that veterans can access care, including veterans nursing homes. And I understand that we've been working in that direction, but to travel 5.5 hours one way to see a specialist and then back again is just not something that we should be putting our veterans through. I also want to note that many of these rural communities in northern Arizona are also tribal communities. Tribal communities that suffer from a lack of resources, a lack of attention from the VA. In the Navajo Nation, the VA undercounts tribal veterans, and it prevents expansion of VA care centers in tribal lands. This is particularly important in northern Arizona and in the tribal Navajo Nation and in the Hopi tribe. Rural and tribal veterans must travel hours to seek the care they need. The current VA health care system is failing our tribal veterans, and we must continue to push on it. I also appreciate the feedback and commitment from the disabled American veterans who work together with me on improving the legislation to ensure that our rural veterans are taken care of. And with that, Madam Chair, I yield back.
Thank you, Mr. O'Halloran. And now I will recognize Ms. McMorris-Rogers for 3 minutes to discuss your bill, H.R. 6647, to make certain improvements relating to the eligibility of veterans to receive reimbursement for emergency treatment through the Veterans Community Care Program. Welcome.
Here we go. Thank you, Chairwoman Brownlee and Ranking Member General Bergman. It's great to be with all of you today, all of the committee members. I appreciate the chance to speak with you about this legislation, my bill that will close a critical gap in veteran emergency care coverage. Last year, a Gulf War veteran from Spokane needed help. She had recently enrolled in VA Health and scheduled her first VA doctor's appointment after retiring from the service. Then disaster struck. Days before her appointment, she was sitting at home when she began experiencing severe nausea and lightheadedness. On the advice of a friend, she rushed herself to the emergency room. She was having a heart attack. Thankfully, she was treated and discharged without further incident. But her problems were just beginning. Despite following the VA's rules and notifying them of her treatment within 72 hours, the VA denied her claims. Since she hadn't been seen by a VA doctor in the last 24 months, she was not considered eligible for emergency care in the community. Thinking there must have been a misunderstanding, she appealed and waited more than a year for a ruling. Denied. It didn't matter that she had just enrolled. It didn't matter that her appointment was just days away. It didn't matter that many VA facilities have 30 to 60-day wait times to get an appointment. And it didn't matter that she'd been regularly seeing a non-VA doctor. The VA stood by the 24-month rule and denied her the coverage she needed. With bills piling high and nowhere else to turn, she reached out to my office, and my team went to work for her to look for a solution. But there was none, only a glaring gap in coverage for veterans in crisis. This is a nationwide problem, and Congress, starting with this committee, must act to address it. Every separating service member faces a gap in emergency coverage when they enroll in VA Health, and it lasts only until they get their first VA doctor's appointment, even if it's a 2-month wait. My bill would change that. The Relieve Act, removing extraneous loopholes, ensuring every veteran emergency, would waive the 24-month rule for 60 days after a veteran enrolls in VA Health. It's a simple fix, and it will give veterans the time they need to complete their first VA appointment at even the slowest of VA facilities, ensuring they will qualify for normal emergency outside coverage and eliminating the gap. Veterans stepped up for us. They put their lives and health on the line for our country. It's time to step up for them. By passing this legislation, let's eliminate the veteran emergency coverage gap now and give veterans the treatment that they need and deserve. And with that, I yield back, Madam Chair. Thank you.
Thank you, McMorris-Rogers. We appreciate that and appreciate your bill, and we will now move on to Representative Higgins. Last but not least, you are recognized for 3 minutes to discuss your bill, the Long-Term Care Veterans Choice Act. Mr. Higgins?
Thank you, Chairwoman Brownlee, Ranking Member General Bergman, and other members of the subcommittee for the opportunity to discuss the benefits of this legislation. I'm especially honored to lead this important legislation with the Chairwoman. The Long-Term Care Veterans Choice Act is something I've been working on for 5 years. I look forward to getting this crucial bill signed into law this Congress. To give some background, medical foster homes are private homes in which a caregiver provides services to a small group of individuals who are unable to live day to day without assistance. They serve as an alternative to nursing homes for those who require nursing home level care but prefer a non-institutional setting. For many young veterans in need of round-the-clock care, medical foster homes can provide a more age-appropriate, independent setting as opposed to traditional nursing homes. But the VA does not cover the cost of medical foster home living arrangements for veterans, although they may be otherwise eligible for nursing home care through the VA. These veterans instead pay an average of $1,500 to $3,000 per month for medical foster home care out of their own pocket or through their private insurance. So although medical foster homes offer nursing home level care at a significantly lower cost, the VA is not able to offer that choice to our veterans. So what we consider is that $3,000 a month in increased choice versus $7,000 a month in restricted choice per patient at a state VA nursing home. This is the issue that my legislation addresses. And VA nursing homes offer an invaluable resource for many. This is true. But there's no one-size-fits-all standard for our veterans. Veterans who sacrifice for our freedom should be afforded flexibility to use the benefits they righteously earned in a manner that best suits their individual needs. Our veterans deserve affordable, quality health care. In order to achieve this goal, the bill does the following. For 5 years, the VA may cover the cost of medical foster home care for up to 900 veterans a day who are otherwise eligible for full nursing home care through the VA. And all medical foster home caregivers must pass a federal background check and undergo a VA screening, participate in annual training, etc. The VA has to be allowed to make unannounced home visits. All the common sense checks and balances are in the legislation. The VA will provide veterans enrolled in this program full interdisciplinary home care, including physicians, nurses, rehabilitation therapists, mental health providers, etc. My legislation is supported by multiple VSOs, and I'd like to offer for the record, Madam, the American Legion, VFW, and DAV writs of support. And I thank the committee for the opportunity to talk about the bill and its merits. I welcome all members of the committee, as well as other veteran-focused members who have any questions, to contact me directly. I very much appreciate, and I'm humbled by my opportunity to speak to you today. God bless you all.
Thank you, Mr. Higgins. And as you said in your opening comments, I am very supportive of your bill and proud to co-author it with you, and we have to work hard to get it through this 117th Congress. So thank you for reintroducing it and pushing forward. I think it's time now to introduce our panel 2. And if they would come up. There they are. You're both are on Zoom, so I think I see you both there now. Okay, so in introducing our second panel from the Department of Veteran Affairs, testifying on camera via Zoom. Before us today is Dr. Julianne Flynn, Acting Assistant Undersecretary for Health for Community Care within the Veterans Health Administration, and she is accompanied by Dr. Scott Hartruth, Executive Director of Office of Geriatrics and Extended Care. Welcome to you both. And just as a reminder to just pause for 2 or 3 seconds before speaking so that the recording will capture all of your words. And any written statement will be included in full in the hearing record without objection. And Dr. Flynn, I now recognize you for 5 minutes for VA's remarks on the bills before us. Welcome.
Thank you, ma'am. Chairwoman Brownlee, Ranking Member Bergman, and other members of the subcommittee, thank you for inviting us here today to present our views on several bills that would affect VA programs and services. Joining me today is Dr. Scotty Hartruth, Executive Director of the Office of Geriatrics and Extended Care. My written statement discusses the bills on today's agenda in detail, but I wanted to touch briefly on these bills now. I want to assure you that VA stands ready to engage with the committee on all of the bills. VA wants to ensure that all veterans have access to the full medical benefits package, including emergency care, from the time of their enrollment, which is why VA supports HR 6647. This bill would fill an important gap for newly enrolled veterans. Coverage for emergency treatment is so important to veterans, and we would welcome the opportunity to engage in a broader discussion with the committee on this authority, particularly in the light of the pending Wolf case. We believe another bill on today's agenda, H.R. 4993, the Veterans Emergency Care Reimbursement Act, raises concerns as to its actual effect because of the ambiguities and technical issues with the bill and uncertainty as to how the court will rule in Wolf. Ensuring veterans, family members, and other beneficiaries can voice their concerns to VA and know how we are responding is important in earning their trust. That is why VA recently launched the Ask VA application, which we believe meets the intent of H.R. 5754, the Patient Advocate Tracker Act. We would be happy to demonstrate this system to the committee and hear from you on ways we can improve this application. Another element of building trust is by ensuring our facilities are open and welcoming places for all veterans, especially women veterans, during all phases of their veteran journey. We are working hard to ensure that our facilities provide lactation spaces for employees and veterans, which is why we support the goals of H.R. 5738. The Lactation Spaces for Veterans Moms Act. We are fully committed to making lactation spaces available, and we can and will find the resources needed to do this. But our biggest impediment is simply the lack of space in existing facilities. We would like to work with the committee to improve VA's plans in this regard. We can also build trust with our veterans by helping them adapt their homes to accommodate their disabilities. VA supports H.R. 5819, Autonomy for Disabled Veterans Act, and believes the bill could go even further by providing a consistent benefit for all enrolled veterans. We are ready to provide technical assistance on this bill to ensure veterans in need of home improvements or structural alterations can receive support from VA to meet their needs. Veterans who need institutional care often want to stay close to home near their families and friends. VA wants to ensure veterans receive appropriate care as close to home as possible, which is why we support H.R. 5941, the Fairness for Rural Veterans Act. We believe some technical amendments to this legislation would ensure that applications for state home projects in rural areas of great and significant need states would receive greater priority in funding, and we would be happy to work with you on this bill. Some veterans may not need to move into a state home or other institution. For these veterans, non-institutional alternatives can meet their healthcare and social needs. We want to support veterans in their choice to live in their homes or other preferred environments for as long as possible. For this reason, we support the draft Long-Term Care Veterans Choice Act, which would save money by supporting greater access to medical foster homes. We look forward to working with your staff to resolve some technical issues with this bill. Finally, we appreciate the committee's work on the Elizabeth Dole Veterans Home and Community-Based Services Improvement Act. This bill has multiple sections designed to support veterans and caregivers. VA recognizes and is grateful for the work that Senator Dole, a caregiver to a veteran herself, has provided veterans and their caregivers over her many years in public life. We greatly appreciate the committee's interest in supporting our efforts regarding home and community-based care, and we think there are many good ideas here. We have already begun discussions with your staff and others, and we look forward to continuing to collaborate on this bill to ensure VA is able to support veterans and their caregivers. In conclusion, I want to emphasize that we greatly appreciate the partnership and work of this committee and the time to discuss these bills with you today. Dr. Hartranft and I are ready to answer your questions.
Thank you very much for that, Dr. Flynn. And I will remind my colleagues that members should, again, pause 2 or 3 seconds before speaking so that all of your questions are captured. And I will now recognize myself for 5 minutes for questions. Dr. Flynn, thank you for your comments around the Elizabeth Dole Act. And, this bill really seeks to accomplish 3 things. 1, make permanent the home care the home care programs VA already has, to expand them all to all medical centers. And third is to coordinate care and services with VA's caregiver programs. So, you know, the Veteran-Directed Care Program is one of VA's crown jewels, and it's been shown time and time again to reduce hospital and nursing home use better than any other VA home program. Satisfaction surveys show the program has never dipped below 89%, yet it is only available at 69 medical centers and serves only 3,400 veterans across the country. So I guess my question to you is, this is an extraordinary successful program. You know, why is it so poorly underutilized? I think we're all in agreement. We don't want our veterans in institutional care if we can avoid it. And it's less expensive than institutional care. So, you know, why is it that it's been so poorly utilized over the years?
Madam Chairwoman, I'm going to yield to Dr. Hartranft. This is his area of expertise.
Thank you, Madam Chairwoman. With veteran-directed care, we are very supportive of its expansion, and we agree that it is very well needed at all VAs. The VA has already started a multi-year expansion program so that by the end of fiscal year 26, we will have a veteran-directed care program at every VA. The reason for the time frame of that is for multiple reasons, to not only include the current funding, but also the fact that that program requires us to make sure that there's plenty of civilian and community resource structures and agencies on disability and aging that are available in that community. So the VA has recognized that great program, and we're very supportive of that. Very happy the committee has been very supportive of that as well. So we are really pushing forward to have that expanded.
Okay, so if I heard you correctly, you said you're going to be able to expand it over the next 2 years?
No, ma'am. It's going to be over the next 4 years. By the end of fiscal year 26, we have currently, we've been very proud of the fact that we're expanding home-based primary care by 75 sites over the next 3 years. Medical foster home is expanding to all sites that don't currently have it over the next 3 years. And then all veteran-directed care was over originally a 5-year window, and now we're almost through the part of FY22. So again, we have plans to have it expanded to every VA by the end of FY26.
Okay, so it was back in 2017 that Secretary Shulkin said it would take 3 years. At our hearing last summer, you told us it would take 5 years. So now you're saying it's going to take 4 years. So that's a lot of time, and we're still not there. My bill requires it to be done in a 2-year time frame. I mean, we can discuss that, but to me, it seems as though, you know, certainly given the caregiver program and sort of the, you know, the heartache of those legacy participants in the caregiver program, they need a place to go. And so that is why, you know, we believe this, you know, tremendous program, a program that is well received by veterans across the country, should be, you know, should be an option for them. So, you know, veterans, they want this, they deserve this. The department should save on the institutional costs and preserve the beds for those who need them the most. So timing in from my frame of mind is really of the essence, and it's taken, you know, it's disappointing that it's taking, you know, so long in order to do it. And it's not a complicated program where you have to find facilities and that sort of thing. It's just, you know, standing it up at every single, you know, medical center across the country. I know it's a little bit more difficult than that, but it is, you know, we have so many other programs where you have to find facilities and lease facilities and build out facilities and so forth and so on. You have a community that wants to participate in this program, you know, in terms of personnel. So I think we just need to we just need to keep moving on that. And I see that my time has expired, so I will now recognize the general for 5 minutes of questions.
Madam Chairwoman, what I'm going to do is I'm going to yield my time and ask my questions last on our side of the aisle, if that's okay with you.
Certainly.
Thank you.
So then I would recognize Ms. Radewagen for 5 minutes of questions.
Thank you, Chairwoman Brownlee and Ranking Member General Bergman for holding this hearing. Thank you to my colleagues for their bills and the panel for your testimony. Dr. Flynn, I know that home and community-based services are often preferred by aging veterans and more cost-effective than institutional alternatives. Does the quality of the care provided to the veterans in home and community-based programs also compare favorably to institutional long-term care services? Why or why not?
Representative Radewagen, I'm a big fan of home-based primary care as well for our veterans. We really want them to stay where they live. I am not familiar with any data on this. I don't know if Dr. Hartranft is, but if not, we'll take it for the record. But Scotty, are you familiar with any data?
We don't have specific data, but we do have, we usually use licensed and certified providers whenever available. Sometimes, though, in rural areas and others, there aren't any licensed or certified providers available. But some of the things that we are doing is that we have been coordinating with the Centers for Medicaid and CHIP services to line our retrospective home and community-based service quality measurement programs. And also, for the first time, we're also started a satisfaction survey for veterans receiving these services so that we get direct feedback from the customers of those purchased services. So we are layering that based with CMS and other entities as to how they provide quality oversight. But I don't have specific numbers, but we can try and provide that to you.
Please do provide that. Thank you. I appreciate it. Dr. Flynn, why do you think medical foster homes are a good alternative to other long-term care options that veterans might have? And where do medical foster homes fit into the spectrum of long-term care services offered by VA?
Again, my permanent job is a chief of staff at the VA in San Antonio, so I'm very familiar with medical foster homes, and I'm a big fan of those as well. But I know when I'm not an expert, so I'm gonna refer this to Dr. Hartranft to answer you, ma'am.
Okay.
Yes, ma'am. Actually, with medical foster homes, the beauty of them is the fact that if a veteran cannot stay in their own home, possibly a medical foster home is a facility or actually home of another individual that has opened their home up to 3 or less veterans to live there. And while they live there, they get their primary care by home-based primary care. So the VA actually provides their primary care in that home. So again, the spectrum it falls in is, yes, the veterans meet the eligibility and requirements for nursing home care, but yet they're able to get that care in a more home-like setting and actually then get their primary care through home-based primary care.
Thank you, Chairwoman Brownlee. I yield back the balance of my time.
Thank you, Ms. Radewagen. I now recognize Mr. Rosendale for 5 minutes of questions.
Thank you, Madam. Thank you, Madam Chair. We're there, live?
I can hear you.
Hello? Okay. Dr. Flynn, the first thing I would like to ask you about is the HR 5754, the Patient Advocate Tracker. Unfortunately, the IT department with Veterans Affairs has not enjoyed a great reputation as far as efficiencies or accountability. And so, I mean, we see problems with the purchase of the programs, overruns, cost overruns, no real definition of what success is. So as we look at the different IT programs that have been introduced, we're not really sure where they're going. The transparency with which the amount of money that has been spent on them has not been well. So All of that being said, when we start looking at electronic complaint tracking system, while I believe that it would be incredibly beneficial system to have in place, can we expect to be purchasing a system that is already developed by someone, quite frankly, because there are a lot of good companies across the nation that have complaint tracking systems that are either automated or handled by live individuals, that we should not have to recreate this wheel. Can we go to one of those firms and try to utilize that?
Yes, sir. What we've done is, if you're familiar with the old complaint system, it was called IRIS. We've just rolled out a new one called Ask VA, and it's on the web, so a veteran can access it on their phone as well. We would love to demo it to this committee and get your feedback, make sure that it is meeting all the veterans' needs. There is a way to track the complaint through the process, so we're hoping to get on your calendar soon to demo that.
That would be great. And Madam Chair, if we could look to you to make sure that we get that on the agenda, that would be really great, because again, there are so many systems out there now that people are using across the nation that if we could have that demonstration to give us some level of confidence that it's going to work, it would be helpful. Also, everyone here is concerned with the labor shortages. Dr. Flynn, you testified today that more pilot programs to recruit aides won't change anything if the VA is having trouble recruiting them in the first place. Could the VA leverage existing long-term care facilities or home aides agencies to make up for that shortfall?
Yes, sir. I'm going to yield to Dr. Hartranft to answer that question.
Hello, sir. Thank you for that question. Actually, with the VA currently with the Homemaker Home Health Aid program, we're actually a customer of that and purchaser of those services for our veterans. And as of the date, since we have had such a large network of home health agencies, we are tracking any time that they seem to be any short of providers for those. And we've received relatively few for such a large national program. But we agree that the shortage of elder care for direct care providers is a national issue that goes much larger than the VA itself. And we look forward to being parts of other groups of seeing how we can be a part of that system to find that larger mix of finding providers of care for veterans and the general public.
Very good. And lastly, Dr. Flynn, the VA has recommended the closure of one of the Montana's community living centers, and the veterans affected would then be transferred to a private facility. The problem is that many of the private facilities in the area have refused to contract with the VA due to the onerous requirements from the VA. Has the department reviewed ways it could make it easier or more flexible to use these private providers?
Yes, sir. I'm going to take that one for the record. I am still digging into that whole market assessment myself, and I'm not the subject matter expert, but we will get you an answer, sir.
Very good. Thank you very much. And Madam Chair, I would yield back. Thank you very much.
Thank you, Mr. Rosendahl. And I now recognize Congresswoman Miller Meeks for 5 minutes of questions.
Thank you, Chairwoman Brownlee and Ranking Member Bergman. And Dr. Flynn, I enlisted in the Army in San Antonio and worked at the VA hospital in San Antonio, so welcome to you. And as a doctor and a 24-year Army veteran, I am proud to co-sponsor of the Patient Advocate Tracker, and I'd like to thank Congresswoman McClain for introducing this important piece of legislation. I'd also like to take a moment to thank Cameron Zukowski with Student Veterans of America for his support of this bill. Dr. Flynn, H.R. 6647, the Relieve Act, would establish a 60-day grace period for new enrollees who have not yet had a VA healthcare appointment to receive reimbursement for non-VA emergency care services. Do you think the 60-day grace period is long enough, or should it be expanded further?
Good to meet an Army colleague. Yes, we actually had an in-depth discussion about this. We think 60 days is a good amount, and we are in support of the bill. And I was remiss, I would love to give Cameron Dukowski a demo as well of the Ask VA program, just to make sure. he's comfortable with it too.
Thank you. And the DAV is going to suggest amending H.R. 6647, the Relieve Act, to include a similar grace period for veterans in need of reimbursement for non-VA emergency care services who have not been seen by the VA in the last 2 years, but have a pending appointment at the time of their emergency. Do you support that idea, and why or why not?
I probably would need to see the details on it. It sounds like the intent is something that we would be interested in talking more about for sure.
Well, thank you very much. Those were the two questions I had. Fully support Representative McLean's bill, and I yield back my time, Chair Brownlee.
Thank you, Congresswoman. And before I get to the general, since he's requested to be last, I'm going to recognize myself for a few minutes to ask some follow-up questions that I wanted to ask, since there are not a lot of members on my side here today. So I wanted to ask Dr. Flynn, Mr. Hartroff, are you aware that there is a belief in the caregiver community that if they are denied access to one program, that that program, that the VA will not help them access, any of these other programs which serve similar needs? Are you aware that that's a belief out there, that they these legacy participants in this caregiver program are being told they have to leave the program, but the VA is not helping them to connect with anything else?
Scotty, I'm going to yield to you. I'm not familiar with that rumor, but it sounds like something we have to squash if it's out there. But go ahead.
Yes, Chairwoman Brownlee. I'm not aware of that, but many of our home care programs, as you know, have been around for 30 years, much longer than the caregiver program itself has been formally. So we really want to make sure veterans are aware that those programs are available regardless of caregiver program.
So then it's fair to say that you are recommending these other programs to veterans that are no longer able to be in the caregiver program, where they can go, and because they've been around for 30 years, that everybody should seem to know about it?
Yes, whenever a veteran, we will be actively pursuing addressing the notion and making sure that everyone is aware. But yes, we've always tried to make sure people are aware of home and community-based services. It's just a matter of making sure that we're getting that message out to particular population, it sounds like, potentially. But no, we're constantly wanting to improve.
So you sit down with them and work through what program might be best for them? Or you just say, hey, here's a menu of programs, go figure it out?
From my understanding, I'm not directly related to the program, but my understanding is that when they transition a veteran from one program, they actually do go through potential care needs and options.
Okay. Last question is, in 2007, the VA instituted VISN performance measures for VA medical centers to create incentives to redirect veterans from institutional care to non-institutional care related to many of the programs that we're talking about today. So they ceased that in 2014. So do you know why they did that? Because it seems as though once they ceased really looking to medical centers and having medical centers account for transition to non-institutionalized care, the numbers to institutionalized care seem to go up quite substantially. So can you give me a rationale why that was stopped?
My apologies, but that predates my having been in VACO since I came in from the field, but we can defer that and take that for the record.
Okay. All right, I will yield back, and General Bergman, you have the floor for 5 minutes.
Thank you, Chairwoman Brownlee. You know, we have a phrase in the military that the that the leaders eat last. So in this case, we'll just transfer it to the questions. I'm not the leader, but the point is I felt it was important to listen to all my colleagues to understand where their line of questioning was going to go. Because what we're talking about here is extremely important, and it's personal for me. Just know that if I was not in Congress right now, having to be here in the beginning of May, I'd be celebrating our 50th reunion of our squadron from Vietnam. And they're going to get together out on the West Coast, but again, my congressional duties supersede that. However, some of the conversations that we're having as, mid-70-year-olds are pertinent to what this hearing is about today and the concerns that as we age and as veterans, what are our options? Because a life without dignity, especially at the end of life, is something that I believe we need to pay special attention to for all of our veterans, because they had the dignity and the perseverance to serve our country. So having said that, Dr. Flynn, I'd really like to take you up on the offer to provide some technical assistance to the committee, on the Long-Term Care Veterans Choice Act. When would you be able to provide that, at least to the Republican committee staff, if not everybody?
Well, sir, first of all, I want to say I lost my dad a year ago. He was a veteran. He died at home. It was wonderful, and the VA did a great job. So I'm with you. We need to allow our veterans to be at home as long as possible and with all respect and dignity the whole way. So I know you didn't ask for that, but I had to add it. I'll work with our subject matter experts to get on your calendar. We definitely want to discuss this further and get this right.
Well, I believe every member of the committee here and all members of Congress, but especially those of us who are honored to be on this committee, want to work with the VA on all matters to ensure that we do the right thing for the veterans sooner rather than later. And so let's talk about, something we always talk about, Dr. Flynn, which is money. Can you please elaborate on the cost savings that the VA could expect if the Long-Term Care Veterans Choice Act were enacted into law?
I am going to yield that to Scotty. Sir, go ahead, Scotty.
Hello, sir. We estimate that the total cost savings resulting from the bill after factoring out the additional costs would be about $14.14 million in FY22 and then also $146 million over 5 years. And of course, that difference being that it is cheaper for a veteran to stay in a medical foster home per rate per month than it is to being in a contractor community or even state veterans homes. So that's where the cost difference is especially since they all must meet nursing home eligibility and admission criteria.
Okay, thank you. And Dr. Flynn, I'd like to, when I was listening to your response to Chairwoman Brownlee's question about why does it take so long to fully implement, a program like the Veterans Directed Care Program, I'm not going to ask you if there's a sense of urgency, but the point is, what I'm going to ask you, what can we do as the committee to shorten that timeline, speed it up for implementation, working together with you all, because there is a sense of urgency, and I'd like to collaborate with you. Any thoughts on how we as the committee might do that?
Scotty, I'm going to answer this a little bit and then you piggyback on, just because I am familiar with the program. It does require a community partner. And so when we rolled it out in San Antonio, we have a wonderful partner with ACOG there, but it does take some time. So I think we could use your help with educating the community about it so that we can form those partnerships in an agile and faster way. That's the only thing I can think of, but Scotty probably has other thoughts.
Yeah, I agree. I think many times of our limitations and even time constraints are really building and finding those community resources to partner with, since it does take that. So again, I think the awareness, the focus, and attention to bringing that to others for us to work with is the critical key there.
Okay, thank you. Madam Chairwoman, thank you for indulging my request to be last, but I guess I'm not last.
It looks that way.
But anyway, thank you.
It looks that way. So I now recognize Mr. Roy for 5 minutes of questioning.
Well, I think the chairwoman, given that votes are, I think, underway or about to occur, and given that I think we've had a good discussion and out of deference to the general's desire to be last, I will just go ahead and say that I think a number of the questions I was going to ask was asked by the general. I do want to say that I'm supportive of Mr. Higgins' legislation and glad that he's got that here. I think that's the right direction, right approach. And with that, I'll shield back.
Very good. So with that, no further questions to our VA colleagues. We thank you for your testimony today, and we will turn to our third panel. Our VA witnesses are welcome to remain and listen to the other stakeholders' testimony if you like. So will panel 3 come forward? I think panel 3 is in the room. So we are pleased to have a range of expertise with us today. Certainly for each and every one of you, your insights on these pieces of legislation are really invaluable to us. Our witnesses are Mr. Anthony Lewis, Associate National Legislative Director at Disabled American Veterans. Understand the first time you've testified in person today, so welcome. Mr. Steve Schwab, Chief Executive Officer of the Elizabeth Dole Foundation, and Mr. Roscoe Butler, who's testified many times in front of the committee, Associate Legislative Director at Paralyzed Veterans of America. So your written statements will be included in full in the hearing record without objection. And Mr. Lewis, we'll begin with you. You are now recognized for 5 minutes for remarks on the bills before us. Welcome.
Thank you. Chairwoman Brownlee, Ranking Member General Bergman, and members of the subcommittee. On behalf of DAV's more than 1 million members, all of whom have service-related injuries, illnesses, or diseases, we thank you for the opportunity to share our views on the legislation currently before this subcommittee. My written statement details our position on all of the legislation on the hearing agenda, but today I'll focus my remarks on the bills related to long-term care for veterans. One of DAV's critical policy goals is to increase access to long-term care. As you likely know, the number of veterans in the oldest age group, those 85 and older, is expected to increase significantly. The number of VHA-enrolled veterans in this age group will grow by almost 40%, and the percentage of veterans who are both 70% disabled and 85 and over is expected to grow by 588%. Recent studies tell us that most aging veterans, around 90%, prefer to age at home or receive long-term care through non-institutional programs in their communities. Some of the words these seniors used when asked were security, independence, and autonomy. That's why DAV is pleased to support H.R. 6823, the Elizabeth Dole Home and Community-Based Services for Veterans and Caregivers Act, and the Long-Term Care Veterans Choice Act. These important pieces of legislation make wide-ranging improvements to VA's home and community-based long-term programs like the veteran-directed care, home-based primary care, and the homemaker health aid programs. Many of the problems that veterans experience with VA's home and community-based services are addressed in the Elizabeth Dole Home and Community-Based Services for Veterans and Caregivers Act, such as inconsistency in the eligibility standards from one VA medical center to another, and geographic alignment of long-term care. In other words, providing these services where veterans live. DAV strongly supports the mandate in the bill that the Veteran-Directed Care Program, the Homemaker Home Health Aid Program, the Home-Based Primary Care Program, and the Purchase Skilled Home Care Program be made available at all VA medical centers. For the full benefit of home and community-based services to be realized, they must be widely available and easily accessible. Another community-based program that many veterans would like the option to use is medical foster homes. These are private homes that offer a small group of veterans long-term care in a more family-oriented setting. However, VA is currently prohibited from paying for veterans' stay in medical foster homes. If enacted, the Long-Term Care Veterans Choice Act would authorize the VA to place and pay for veterans in medical foster homes, as long as those homes pass VA's inspection and certification. Madam Chair, as I mentioned, aging veterans have told us that security, independence, and autonomy are very important to them. Home Improvement and Structural Alteration Grants, or HISA grants, provide funding for essential home alterations for disabled veterans, consequentially giving them security, independence, and autonomy. That's why DAV strongly supports H.R. 5819, the Autonomy for Disabled Veterans Act. Congress last increased funding for HISA grants in 2009. Due to inflation, HISA grants no longer cover the actual costs of these essential home renovations. It's imperative that Congress adequately fund VA's home and community-based programs. But we remind Congress that there will be a tremendous need for both institutional and non-institutional in the near future, and that VA must have significantly increased funding for both. So rather than shifting resources from institutional care and into home-based care, we urge Congress to take the approach of growing both, but home-based care at a faster rate than institution-based care. DAV is committed to empowering service-disabled veterans to lead high-quality lives with dignity and respect. Ensuring access to long-term care is a part of that cannot be forgotten. Our veterans deserve better. Again, thank you, Madam Chair, for allowing me to be here to testify, and I'm looking forward to answering your questions.
Thank you, Mr. Lewis. Excellent job. Mr. Schwab, you are now recognized for 5 minutes. Welcome.
Chairwoman Brownlee, Ranking Member Bergman, and members of the subcommittee. On behalf of the Elizabeth Dole Foundation, I am pleased to testify on the Elizabeth Dole Home and Community-Based Services for Veterans and Caregivers Act. The Elizabeth Dole Act is named for a revered public servant who has devoted her life to building coalitions of Americans to solve our nation's greatest challenges. Fittingly, the bill is a true reflection of Senator Dole's legacy. It helps uphold the promise our nation makes to military families bearing the wounds and illnesses of war. And it is precisely focused on providing solutions that are worthy of bipartisan support and that will directly address the most common and persistent hardships of our veterans, their families, and their caregivers. In the 10 years since the Elizabeth Dole Foundation was established, we have commissioned consequential and groundbreaking research on military caregivers, veterans, and their families. We have also grown the most active and trusted network of caregivers and their supporters in the nation. The Elizabeth Dole Act addresses key systemic issues we have chronicled through our work, both anecdotally and through evidence-based studies. Among its many priorities, this legislation will first reinvest in caregiver support at the U.S. Department of Veterans Affairs. Second, it will expand VA home and community-based services. Third, it will provide greater access to critical resources. And fourth, provide an online hub that helps caregivers determine which VA services they are eligible for and how to apply for them. These reforms are critical to the wellness of caregivers and their veterans. Consider what we know about military caregivers. More than 5.5 million adults and 2.3 million kids care for a veteran at home. Together, they provide over $15 billion worth of unpaid care every year, dollars that save the system a lot of money. As a consequence of this incredible responsibility, caregivers suffer more health problems than non-caregivers. They experience rates of anxiety up to 4 times those of their peers. They report increased strain in family relationships, and they face devastating legal and financial challenges. We know that right now, thousands of caregivers are being transitioned out of the Program for Comprehensive Assistance for Family Caregivers. This transition means the loss of financial support, access to mental and emotional health services, and other key lifeline benefits. There is a lot of discussion surrounding whether this is the right path forward, but I want to make one thing absolutely clear to our community and to our friends in Congress. The caregiver program, PCAFC, should not be seen as the end-all be-all for caregiver support at the VA. This legislation aims to combat that perception and bolster the programs that are already readily available for these families, lessening the pressure of being accepted into PCAFC. This act will enroll caregivers who are found ineligible for PCAFC into the VA's program for general caregiver support services. This program directly concurs with a key recommendation made by members of the Veterans Family and Survivor Advisory Committee, chaired by Elizabeth Dole. Rather than force overwhelmed caregivers to participate in another evaluation process, this optional enrollment would provide a seamless transition to another supportive program. Our foundation is very supportive of the bill's expansion of home and community-based services. The COVID-19 pandemic demonstrated that our health systems have the capacity to effectively provide care in the home, and it importantly proved there is a huge appetite to do so. We also know that wounded, ill, and injured veterans are more likely to thrive when they can convalesce in their home with their loved ones. Home care services also provide valuable opportunities to evaluate and connect with caregivers. Currently, most caregivers only interact directly with the VA when they are in PCAFC. And Chairwoman, you asked an important question about that. We agree with you. Too many caregivers are struggling with depression, substance abuse, and suicidal ideation, and they need more touch points with VA staff. This bill calls for VA staff to more regularly check in with those caregivers and their veterans and identify substantive ways that they can be supported. It also calls on the VA to create opportunities to expand mental health services to caregivers, important research to understand what those needs are. We know all too well the value of mental health support, but it is among the many benefits caregivers lose when they are transitioned out of PCAFC. Chairwoman Brownlee, members of the committee, we were honored and humbled when you asked to name this legislation after Senator Dole. She was moved beyond words and grateful that this committee is recognizing the vital role that hidden heroes play in the care of America's veterans. We strongly encourage broad bipartisan support for this bill, and I look forward to answering the subcommittee's questions. Thank you, Chairwoman.
Thank you, Mr. Schwab. And finally, Mr. Butler, you're now recognized for 5 minutes.
Chairwoman Brownlee, Ranking Member Bergman, and members of the subcommittee. Paralyzed Veterans of America would like to thank you for this opportunity to present our views on pending legislation impacting the Department of Veterans Affairs that is before this subcommittee. No group of veterans understand the full scope of benefits and care provided by VA better than PVA members. Veterans who have incurred a spinal cord injury or disorder, several of these bills would help to ensure veterans receive much-needed aid and support. However, since you have my full testimony, for the sake of time, I'm limiting my time to discussing the Elizabeth Dole Home and Community-Based Services for Veterans and Caregivers Act, but I strongly encourage everyone to read my full and complete testimony. PVA gives its strongest support to H.R. 6823, the Elizabeth Dole Home and Community-Based Services for Veterans and Caregivers Act. This critically important legislation would make urgently needed improvements to VA's home and community-based services that target our concerns about current program shortfalls. Section 2 of this bill would raise the cap on how much VA can pay for the cost of home care from 65% to 100% of the cost of nursing home care. I would like to share a few examples of why this legislation is important to our members. A veteran residing in California had to move and change where he received his health care. The VA Medical Center where he previously received his care were authorizing 56 hours of expanded care a week. The VA Medical Center where he currently receives his care is only authorizing 24 hours per week. The reason the VA Medical Center provided was to keep his hours under the 65% cost cap. They were unable to approve more coverage. The veteran and his family are currently having to choose between reduced home nursing support and facility placement because of his family is unable to safely provide the additional care. He needs to supplement the newly authorized amount. The wife of a veteran in North Carolina is currently responsible for providing her husband with 108 hours per week of home care due to the 65% cap. She has experienced caregiver burnout, and the care of the veteran has noticeably declined. Now he is at risk of facility placement. Raising the cap would allow veterans whose cost of care exceeds the present cap to continue to receive appropriate home community-based services. Most importantly, it would allow them to maintain their care in their home or other similar locations, which is the preference of most veterans. PVA member Steve McIntosh, current caregiver, is his elderly father. As you can imagine, his dad cannot do as much as he used to, and his ability to care for his son will diminish as he continues to age. Mr. McIntosh expressed concerns about his situation during his annual SCID exam and asked about the availability of the VDC program to provide him additional care. Regrettably, the program was not available at his VA facility. Our members and other veterans are consistently asking for help in getting this program implemented at their VA healthcare facility. PVA member Milton Young has been waiting over 2 years for the Cleveland VA to implement the program. In January, the VA announced plans to add new VDC programs at 70 medical centers over 5 years. While we support this effort, many veterans need access to VDC care now. We greatly appreciate the accelerated schedule this legislation would provide so every VA medical center can offer a robust VDC program as soon as possible. We also strongly support language that would allow catastrophically disabled veterans like Ann Robinson, who is a PVA member living with quadriplegia, to continue to use funds under the VDC program during a period of hospitalization to retain or hire an attendant to assist with their non-medical needs during hospitalization. PVA, once again, would like to thank the subcommittee for the opportunity to present our views on the legislation being considered today. We look forward to working with the subcommittee on this legislation and would be happy to answer any questions.
Thank you so much, Mr. Butler. I appreciate that, and I will now recognize myself for 5 minutes. We're going up against the clock here in terms of votes on the floor. But first, Mr. Schwab, let me just say what an honor it is to have Senator Dole's name on our bill. She has been just, as you said, and just incredible in terms of advocacy for caregivers across our country. And as you describe them, that are hidden heroes who are doing this kind of work every single day under excruciating circumstances. And so we are grateful to her, and we are grateful to all of the caregivers across the country. And I think, the reason why this bill, I think, is so important is because finally we have the ability to care for our veterans at home where they want to be. We will have services to take care of the caregivers. It's really win-win from that perspective. And I think an important point to make is not to be confused with the caregiver program, is this is for every veteran where it's medically deemed necessary. So this isn't just for disabled veterans. This is for every single veteran who has served our country, can stay in their homes with the help of professional and willing caregivers, be it family, be it professional, be whatever he or she has in order for that caregiving to happen. So I just, I want you to just describe a little bit the experience that you're aware of veterans who are denied or discharged, from the caregiver program, and how, tell me how you think they discover the veteran-directed programs. I asked that of the first panel. It seems to be like it's a program that's been there for 30 years, and you should know about it. But tell me what you've been hearing from our veterans across the country.
Sure. Well, thank you, Madam Chairwoman, first for acknowledging Senator Dole's service. She's actively watching today's panel from home. And she's so deeply appreciative of your leadership, of the ranking members' co-sponsorship of the bill, and the committee's focus on this important topic. Thank you for also asking about the experience of our community right now, because it's been pretty rough. As has been mentioned several times in today's hearing, vis-a-vis the Mission Act, the Program for Comprehensive Assistance is going through an expansion. And most people hear that word and they think that means that a lot more people are coming into the program, and that's certainly true of folks in the pre-9/11 category who were, prior to the Mission Act, ineligible to be part of the Program for Comprehensive Assistance. But what it's meant, and you've mentioned this several times today, we thank you for that, is a lot of legacy caregivers, thousands of them, mostly post-9/11, who are struggling to care for many of them severe mental and emotional wounds, injuries, and illnesses, are being transitioned out of the Program for Comprehensive Assistance. And while the VA and the groups we've worked with have ensured that there is a bridge between now and when that transition will happen, the manner in which it's happened has not been uniformly done well. In fact, it's been painful and stressful and anxiety-ridden for almost all of the folks who've gone through it. That's what we're hearing right now. And we know that they've happened at times like the week before Thanksgiving and the week before Christmas. And so in as much as the VA, and we credit the VA, of course, for doing a lot of work around implementing the Mission Act, there is a huge inconsistency issue happening across the country with respect of the way these evaluations and these communications and this dialogue is happening. With respect to the VDC and other services, the most common question we receive at the foundation from veterans and caregivers is, where do I find the information? How do I find out what I'm eligible for? And so the beauty of this bill, this bipartisan bill, is that we're going to create an environment online where folks can come to the VA website and find all that information in one place. In a hub, we've been asking for this for years. the reality is that if someone's interested in VDC, they go to the geriatric part of the VA's website. If someone's interested in a caregiver program, they've got to search through the caregiver website and probably 2 or 3 or 4 pages down to find the information they need to find. And this isn't, a hack at the VA but it is a demand that we make information accessible and readily available. And as you said, Madam Chairwoman, require that VA officials, when someone is transitioned or is moved to another program, that they have a conversation with a social worker or a VA medical professional on what they're eligible for, can be pointed to a single destination where they can find the information. So this bill really does address some key root systemic issues for caregivers and veterans while vastly expanding support that many of them are due.
Well, thank you for that, and my time has run out. General Bergman, do you still want to remain last in this process? Okay, we've got Ms. Radawagan, I think, online, and I will call on Ms. Radawagan for 5 minutes of questions. Ms. Radawagan, you're muted.
Thank you, Chairwoman Brownlee. Mr. Schwab, the Elizabeth Dole Act is fairly comprehensive long-term care legislation. That said, are there any priorities of the Elizabeth Dole Foundation that are not addressed in the bill that you think should be?
Wow, that's a big question. Thank you for that question. And Congresswoman, we'd love to meet with you and your staff. Most of what we've been calling for through our advocacy agenda and much of the work that and recommendations that Senator Dole has been making alongside her colleagues on the Veterans Advisory Committee for Caregivers, Survivors, and Families, the fundamental recommendations are represented in this legislation. As I mentioned, some of the root systemic issues that have plagued this community are addressed in this legislation. There's certainly more that we can do, but we're extremely pleased that that much of what the community needs right now is in this legislation. I will be speaking next week at another hearing, in a Senate hearing, about what we believe needs to happen to address the huge issues that are happening with caregivers who are being transitioned out of the Program for Comprehensive Assistance. But again, this legislation also, as the Chairwoman has mentioned, offers a whole suite of services and support for caregivers that they're not eligible for right now.
Is the Elizabeth Dole Foundation supportive of medical foster homes? And if so, do you have any thoughts as to how we can give better support caregivers in medical foster homes? If not, why not?
Thank you for that question, Congresswoman. Interesting timing, because as we were listening to the dialogue around the legislation that is on the agenda of this committee's work today around foster homes, I turned to my colleague and said we ought to explore our support for the bill that's on the agenda today. So yes, we are supportive of veterans convalescing where they want and when they want, at home, in a foster home. And we're actually studying the bill that's on today's agenda, and we'll be eager to report back to you once we look into that matter a little bit more.
Okay, thank you. So this is for all of you. What, if any, feedback do you hear from your members about medical foster homes? Do you have any suggestions other than the enactment of the Long-Term Care Veterans Choice Act about how to better educate veterans about medical foster homes? Anybody else want to answer?
Thank you, ma'am. Yes, so what we've heard is that medical foster homes are preferable to nursing homes for a lot of veterans. And that's why we're so supportive of this legislation that allows VA to actually pay for these foster homes for veterans who are otherwise eligible for nursing home care from the VA. One thing that DAV wants to make sure of is that The spread of infectious diseases is something that's looked out for. People who live in group living quarters are more susceptible, like we saw at the outbreak of the current pandemic. So we just want to make sure that VA has an eye on that.
Okay, I'm just about out of time. Is there anybody else there who wanted to answer this question?
Thank you, Congressman Ratterwigan. I'll just say briefly, PVA supports the medical foster home, but I think in this environment with COVID, we need to make sure that because it's a close environment, 3 or less veterans, that when they enter into the medical foster home, that they have been vaccinated and preferably had the booster shot as well.
Thank you, Chairwoman Brownlee. I yield back.
Thank you, Ms. Radewagen, and I will now recognize Mr. Rosendale for 5 minutes of questions.
Thank you, Madam Chair. I'm going to start off with Mr. Schwab. The VA, unfortunately, is recommending that 3 clinics and a long-term care facility be shut down in northeastern Montana. That's going to leave veterans literally hundreds of miles away from the next VA facility. Where would you direct VA resources to ensure that our veterans have the care that they were promised? And how should the VA be engaging in private facilities to fill those gaps to make sure our veterans are kept in a familiar environment and also continue to receive that quality care?
Well, Congressman, thanks for the question. First, I'd like to say that we strongly support the process that this committee in Congress has ensured will take place around reviewing the recommendations that the Secretary and the VA have made about, the destiny of facilities all across the country through the Air Commission, and I understand that those will be reviewed by the Commission and come back to this Congress. So at this point, we understand them as proposals. Having said what you said, there is a lot of stress and concern across the community right now about what has been recommended. I know in Montana particularly. And your question to me was, what advice would I have to families on where to look for those?
Where do you think that we should be directing these resources to make sure that these veterans can maintain care in a familiar environment and quality care? I mean, everybody talks about autonomy and security and all these things. That's what we're talking about.
One piece of advice that we give to veterans that call us when they are in a rural area or remote is we either work with them directly or refer them to a caseworker that can walk them through all the ways that they can access remote care, because so much of that care has so much of what the VA can offer now can be accessed remotely, but that's not satisfactory to a lot of veterans. So we have a program at the Elizabeth Dole Foundation where we work with 180 communities across the country, where we've designated community partners, work with community partners through our Hidden Heroes Communities program, where we can refer families to other resources in the community, community providers, et cetera. That's the advice we regularly give families, is accessing remote care or working with one of our community partners that we've identified.
Mr. Lewis or Mr. Butler, would either of you give me some guidance here what I'm supposed to tell my veterans when we get 3 clinics and long-term care facility closed?
I think that it's important that VA, while it's looking at the services it offers, it ensures that the services are available in the community, because if you're closing down and restructuring facilities and services, you need to ensure before you go down that road, the veterans have access to the services within the community. And I know firsthand, for example, in Hot Springs, and they're talking about closing the Hot Springs facility. When I worked for the American Legion, and when we went out into the community facility to ask if they are capable of providing the care or services to veterans, and they told us that they weren't. And so VA needs to ensure, as it goes down this road and path, that there are adequate resources to bridge that gap while they're restructuring and building up its system.
Yeah, I just feel, and I'm sure that you do, all three of you, that the communities that are rural or frontier, that the veterans' benefits are supposed to be delivered at the same level with equality and equity that we always hear about, that they are in urban areas. And while we may get good reports from the urban settings because there is an intense population and it's easier to build these large facilities up that are exclusively for the use of the veterans, my veterans should be able to have access to that same quality of care as well. And if the Veterans Administration can't provide it, then we should be able to go into the community. The veterans should be able to go into the community and get that from someone else. Would you all three agree to that?
Agree.
Absolutely.
Would anybody like to make, well, I've only got 8 seconds left, but maybe you can drag over and use a moment of someone else's time if you'd like to comment on that. Thank you. And if not, I will yield back, Madam Chair.
Thank you, Mr. Rosenthal. General, your time has come.
So let's be brief. We have votes. I'm going to focus here on my questions because we focused in on several of the key elements of legislation here. I'd like to focus on my questions here just very quickly on H.R. 5819, the Autonomy for Disabled Veterans Act. Mr. Lawson out of Tallahassee. On our previous panel, VA testified that the HISA grants, and that's home improvement and structural alteration grants, should be available to all disabled veterans, regardless of service connection, in the amount of $9,000. Do you support, this is for all of you, do you support that proposal? And if so, why? And if not, why not?
I speak for PVA. We have.
And by the way, if you don't have an opinion, you can take it for the record.
PVA has a proposal that would raise the rates for both service-connected and non-service-connected veterans. So we haven't considered having a single rate, but we would be eager to look at that and report back to you if we would support that or not.
Okay. Do you have any other, because you're looking at it, do you have any other thoughts, Mr. Butler, on, from your perspective on what else we might do?
I'll take that for the record.
Great. Well, and I appreciate that because when you put it in writing, then it gives us a chance to take a look at it. Anybody else have a comment?
I would just say, Ranking Member Bergman, we'd be happy to take that for the record and get back to you. We are working with our colleagues to study that issue more closely, and we'll do so with more speed now, given your inquiry.
Okay. Mr. Lewis?
Yes, sir. So DAV's membership does have a resolution to raise the amount of HISA grants. As far as a specific amount, I also will take that for the record and then get you an answer.
Thank you. And I'm just going to end and yield back some time here, but to say that as we talk about veterans, whether they be disabled or not, the ability to live independently for as long as possible, and then when they do have to transition to whether it's a veterans home, a foster home, whatever, there is opportunity for us as Congress working with the VA, I believe, to do wise things going forward for our veterans. So with that, Chairwoman Brownlee, I yield back.
Thank you, General. And I think we're going to have to conclude this hearing because sadly they've called us for votes. I would sit here for a long time talking about these bills if I could. But let me just conclude by saying I think, all of these bills that we have looked at today are important, particularly as the general said, to make sure that people have the option to be at home for as long as possible. Over 50% of the veteran population now are 65 years and older, so there's really, I call it the senior tsunami coming through, and that's why we really have to act, now. We've got to get these programs up to speed and scaled up across, across the country and provide the supports we need for our caregiver. So I'm looking forward to working on these bills and certainly on the Elizabeth Dole Act. And I'm very glad that the Senate's going to take it up. We have senators who have signed on to the bill. It's a bipartisan bill because the general is going to work with me here on this side, but I know with the help of all of the veteran service organizations, particularly the paralyzed veterans and disabled veterans, are here to help, and certainly the foundation is here to help. So I look forward to the work ahead, and I look forward to many more discussions around this. And I know that the VA is anxious to talk to us about the bill, too, in terms of making some minor tweaks and changes here and there. So we will do that. And again, I thank you all for being here. And it's I think I have to technically say that all members will have 5 legislative days to revise and extend their remarks and include extraneous materials. And with that, I thank you all, and without objection, the subcommittee stands adjourned. Thank you.
Thank you.